afternoon program. And I'd like to welcome everyone to the mental health discussion panel on measurement-based care in mental health and addictions. Why is it still not standard of care? This is hosted by the Canadian Institute for Military and Veteran Health Research, and we're going to talk about the problems and challenges of measurement-based care and how we can improve outcomes.
Today, we are located on the Treaty 1 territory, the home and traditional lands of the Anishinaabe, Innu, and Dakota people, and in the national homeland of the Red River Métis. Nous respectons les traités qui ont été effectués sur ces territoires. Nous reconnaissons les dommages et les erreurs du passé. Nous sommes engagés à mener de l'avant notre partenariat avec les communautés autochtones dans un esprit de réconciliation et de collaboration. I'm a francophone in a Canada that is mainly anglophone. I believe in reconciliation. I believe in working together. I believe that my Canada is about working all together. So, thank you.
Hi there, this is David Pedler again. So now it's a real pleasure to introduce our MC today. That is Lieutenant Colonel retired Rakesh Jetley. Rakesh is a CIMVHR fellow who's been a long time, I'm sorry, Colonel, my notes were wrong, I apologize. My apologies, who's been a long time supporter of CIMVHR and is the CIMVHR Mental Health Advisor. We're really grateful to have Colonel Jetley retired here to lead us through this important discussion. Colonel Jetley.
Thanks very much, Dave, Stephanie, and thanks to CIMVHR, like really for sort of giving us this platform, and of course my esteemed panelists, who every one of whom responded to, "Hey, would you mind doing this with me, coming to Winnipeg for a day?" And so everybody, so I really appreciate that. Our attendees, of course, and we've got many people online, virtually sort of attending this conference. So for the virtual attendees, your mics will be muted, but you can use the chat function to ask questions, post comments, as long as they're positive, of course, and there'll be a chance to do that. We've got a very diverse group of panelists, in the sense we've got sort of scientists, clinicians. We've even got a surgeon that's now an expert in population health. So it's really going to be fun to sort of listen to where things are coming. This topic, sort of measurement-based care, has been sort of coming up and down, again, for my career, which has been kind of long over, but the last year or so is becoming more and more important. And why it's important for me really is because I'm struggling with all the good research that we're doing, the population health things. We really haven't budged the yardstick on response to treatment, right? There's still, 60, 70% of people still meet the criteria for PTSD after treatment. So what we need to do is we need to really look at, maybe embracing new therapies. Maybe we look at the third and fourth wave of psychotherapy that people talk about. There's health coaching, there's interventional approaches. But maybe measurement-based care is one of the ones that we've always sort of had, but haven't really used it to the best of its potential. And could it lead to sort of better outcomes, more efficiency, and allow us to do it? In December, the CIMVHR group and we met, and we were considering sort of strategic mental health things over the next little while. And as a group, we all kind of agreed that this would be one of the things that we should really focus, became number one. So the fact that we're able to make this as our decision and by April have our first panel, I think that's, kudos to the team, and thank you very much for that. So this panel is the beginning of this discussion. It's not the one and done. This isn't the end. So I think just as we're trying to get sort of more interest, the panel itself, what I'd like you folks to think about as you're watching it is there's a bit of a story arc involved, right? There's a story arc involved, just like your favorite Netflix series or your favorite movie, in the sense that, I've asked Denise to do like a dispassionate scientific review. We're all kind of saying, hey, it's good, it works, all this, but does it really? Let's start off with that piece. Brian's going to talk about the Canadian Armed Forces experience at Chromis, our OQ45 based tool that we've had around for a long time. Venkat's going to talk about implementation science. That's a really important piece, and I want you to think about implementation throughout all the talks, really, because how we actually, the best idea in the world, if it's not implemented right, isn't going to work. Now, I come from an organization retired a couple of years ago where we have this habit of, we're from headquarters, we have this great thing, here you go, right? Use it. And what happens then is sometimes you're burdening people with, very, very busy people that are full. You're burdening them with sort of more work and things like that. That becomes difficult. And then we're going to end off with a note where we're going to have sort of, Pam Hollins and Anne Germain are going to talk about 2 examples where measurement-based care is being used in clinical practice. So end with a bit of an optimistic note, and then we'll have a sort of discussion afterwards as a group. So I just want to sort of have that idea of like the arc, so the intent of the panel, and then an open discussion afterwards. And then the idea that we're going to sort of watch it with the lens of implementation, because just because something's a good idea doesn't mean it's going to translate and we're going to automatically get the buy-in. I'm just going to show the first couple of slides here, and then we'll. Yep, so this is accredited by the Royal College for an hour and a half, I guess, if you attend the whole thing. This is the planning committee disclosure. So Shaylee Bolton, thankfully local talent, just sort of stood up and really sort of helped a lot, and a lot of hours going back and forth with the documentation. I'll tell anybody else that wants to do this for an event, start early, start early and be patient. And the team really came together in the last sort of month, which is March break and Easter for everybody. So appreciate that. Just in terms of the disclosures, so for me, I just put everything I do because I've got to make a living. And so different speakers bureau, I do some consulting with the United Nations, the Edgewood Health Network. I'm the chief medical officer of Minus Innovation Group, sort of a small biotech company. Dalton Associates that sort of look after the OPP, the MedCan Clinic in Toronto. I'm the advisor for CIMVHR, so those are kind of my disclosures. And Dr. Serene is a member of the advisory board for Up to Date. And mitigating the potential bias. So in this specific case, it's not going to be an issue for me personally, because I'm not talking about any of the specific agencies that I'm involved in. I'm just happy to be here, and CIMVHR is certainly a conflict, but I'll state my bias, and everybody should go to the conference in the fall. So that's it. And Dr. Serene's, it's unrelated to the topic of the forum as well. Okay. And we're going to hand it over to Denise, and we're going to keep the timing short. The speakers are going to come just in one sentence, say who they are and their affiliation, and then go. We're not going to read sort of bios, and we're all going to keep this as casual as possible. So Denise, take over.
So good afternoon, everyone. My name is Dr. Denise Ficratolo, and I'm a defense scientist at DRDC Toronto. And today I'll be giving you a brief overview of the scientific literature on measurement-based care, specifically in mental health care settings or behavioral health care settings. I'll try to focus the discussion around definitions, the evidence for efficacy, and some issues around implementation that Rakesh has also referred to. I have nothing to disclose, unfortunately, no financial relationships. And these are the learning objectives for the whole panel and the whole series of presentations. First and foremost, to understand the potential benefits of measurement-based care, especially for the patients, but also at the healthcare system level, to describe the commonly encountered or experienced barriers to successful implementation. And finally, we are going to hear from some speakers who have experienced successfully implementing measurement-based care for things like insomnia and chronic pain, which I think is going to be really helpful. So I'm a psychologist by training, and thus I will start with the American Psychological Association's definition of measurement-based care. In a nutshell, measurement-based care refers to an evidence-based practice that involves the routine and systematic collection of the patient perspective with the goal of improving treatment, for the patient over the course of the treatment. And we start at the first session. The idea is we start at the first session at intake, and we do this systematically over the course of the treatment, and we don't stop until the treatment stops. Okay. So measurement-based care was introduced partly in response to research that showed that in its absence, without measurement-based care, clinicians may have difficulty identifying patients who may not respond to treatment as we would like. And as well, they may have difficulty identifying patients who may actually start doing worse during the course of treatment. Now, it's really important for us to specify what we mean when we talk about measurement-based care. So on this slide, I try to put up the 4 key components of measurement-based care. The first one, there is no controversy. We are talking about measurement, and we are talking about doing it routinely and systematically to get the patient's perspective. The remaining components are perhaps more controversial and include practitioner review of the data that we are collecting, the patient's review of the data, and perhaps most importantly, the patient and the clinician collaboratively working together during the clinical encounter, reviewing the data and changing course if and when that's called for, and making adjustments to the treatment plan. Now, when you look at the scientific literature on measurement-based care, you'll find out that there are a lot of different terms that are being used, and not all of them are the same, which is very important for us to be aware of. There are at least as many as 16 different terms, including things like patient-reported outcome measures, clinical or client feedback systems, et cetera, et cetera. Now, of the 4 components, the 2 that are most frequently omitted, interestingly, are the patient review of their own data and the collaborative working together between the clinician and the patient to make adjustments to the treatment so that it works for the patient. So there's a problem with underspecification of the term, and that has implications for how we interpret the scientific evidence across different studies that may use different definitions of measurement-based care. It also has implications around understanding how strictly do we need to adhere to measurement-based care for it to work, and how much flexibility is there with respect to each of those components. Now, in terms of efficacy, this is from the APA's website for measurement-based care. You can kind of see that going back to 2017 or so, we have at least 51 randomized control trials. And across these studies, we see evidence for measurement-based care leading to improved patient outcomes. Now, later reviews, which included qualitative studies as well, also showed that measurement-based care is associated with decreased costs, which is important at the healthcare system level, and lower likelihood of patients deteriorating during treatment. And finally, the most recent review that you see listed on this slide shows that there is a beneficial effect for all patients, but most importantly, a larger beneficial effect for patients who are at risk of not responding during treatment, which is like the patient group that we are most interested in helping out. There are some caveats around this scientific literature that we also need to be aware of. So there was an excellent evidence brief that was published by the US Veterans Administration recently, and they noted that a lot of studies out there on measurement-based care have low methodological quality. So we have to keep that in mind in interpreting the scientific literature. Studies don't do a great job of adequately, sufficiently describing what they mean by measurement-based care and how successfully it was implemented. So if you look at a study where there's no beneficial effect, you don't know whether that's the case because the approach doesn't work or because it was implemented poorly. There is also a lack of information around patient characteristics and provider characteristics that may differ across the control and intervention arms in our RCTs. So that's a potential source of confounding. And finally, we really need to look at the value of measurement-based care using independent measures, not those that are part of the measurement-based care intervention. In addition, there's also emerging literature that shows that in certain patient groups, this may not be the right approach. So there's a recent study that I list on this slide in 2018, where it was shown that in cluster B and personality disorder not otherwise specified patients, measurement-based care led to the opposite effect. Not what we are looking for. So patients ended up having increased symptoms over the course of the 6 months. So this is kind of emerging literature. It needs to be replicated, but it's something that people should be flagging and paying attention to. So very quickly, the implementation of this evidence-based approach has been less than optimal. So you can look at the broad literature across civilian, military, and veteran healthcare systems. And depending on how you define successful implementation, you may find that less than 20% of the practitioners out there are using measurement-based care, or you may find that around 5% use it. So that's quite abysmal, right? And importantly, I am putting successful implementation in quotation marks because you'll find that each study describes that, defines that differently, and we really need to think about how we define implementation success for early on, during the early stages of implementation, and then later. In Canada, I won't say too much here because I have a colleague who's going to be coming up and talking about the Canadian Armed Forces experience with measurement-based care in mental health treatment. Our experience is very similar to what you see in the broader literature. Implementation has been challenging. So when we look at early reports from the implementation in Veterans Affairs Canada, if you look at the clinician self-reports, it looks like there's no problem. So I think 83% said, yes, I am administering the measure. 78% said, I am reviewing the results. And 65% said, yes, I am also discussing it during the session with my patient. But when you look at the system level data, those self-reports are overestimating what's actually happening. And importantly, when somebody gets flagged as not being on track, they are not receiving the assessment that should be given to them. So I won't say much about the Canadian Armed Forces experience. There was an early report from a single clinic which showed that not all of the eligible visits were seeing those measures being administered, let alone reviewed by the treating clinician. In the US VA system, which is one of the largest healthcare systems, there was a 13-step implementation plan. There was a whole range of clinical guides and tools and videos to help clinicians use measurement-based care And yet, when you look at early reports, there's a 2020 study that I'm referring to at the bottom of the slide here. Success was less than optimal, so around 25%, when success was defined at a very low threshold. So patients receiving one or completing one or more measures, which, going back to those 4 components, is not measurement-based care. All I will say here is that this is really somewhat surprising, given that we have a field of study called implementation science with sophisticated theories, models, and frameworks that should tell us how to take research and put it into practice, to think about factors that may drive implementation success or failure, and how to evaluate implementation success or failure. As well, based on these theories, models, and frameworks, we have a large number of implementation strategies. And yet, when we look at what's actually happening, something is not fitting there. I would propose to you that part of what's going on is that it's not enough to say, hey, you know, this strategy sounds like a good idea. It's not going to cost much. We really need to be very, very precise about naming it, defining it, and operationalizing it to say who's supposed to do what, for how long, how frequently, who's the target of this behavior, and why not to use the strategy. I don't have time today to go into the details of all of the professional and ethical issues that arise when you introduce something like measurement-based care into a large healthcare system, but those issues do exist, and we do need to pay attention to them and plan for them. I put up an excellent article that I hope people will check out, which lays this out at the patient level and at the provider level and at the system level. So at the provider level, for instance, what happens when the measurement-based care data shows that a given provider is not performing well? Do we compel them to seek treatment, to continue to work with that patient population with whom they are not producing great results? Or what do we do? And at the system level, we need to think about how do we use such data at the system level? Do we start matching certain patients with certain clinicians? It sounds like a really good idea, but when you look at the research, on the one hand, it shows that it can benefit individual patients, but if you do it at the system level, you might start taking clinicians who are doing really well and you keep assigning difficult cases to them, their performance goes down. So it's not that easy. So just to quickly summarize within the time limit that I've been given, measurement-based care is an evidence-based approach, and we do know that it improves patient outcomes when done right. It's been challenging to implement, and we really need to think about how we do implementation science moving forward. What I would propose to you, that I hope other speakers will also touch upon, is we need to do better in terms of selecting implementation strategies at the outset and being very precise about what those strategies are and why we are selecting them, being very precise about what implementation success should look like. And we need to start linking the components of measurement-based care and the proposed mechanisms of change that I wasn't able to touch upon today. And finally, the ethical professional issues within large healthcare systems is not something that we can ignore. and just wait for it to kind of unfold as we introduce measurement-based care. So with that, I'll stop and turn it over to the next person.
Thanks, Denise. So good day. My name is Brian Garber, and in the next few minutes, I'll provide a brief overview of the Canadian Armed Forces experience with implementation of a measurement-based care system in our mental health clinics. So in terms of disclosure, I have no financial relationships, although I will disclose that I was originally trained as a surgeon. And I would have to say that working with mental health professionals has helped put me in touch with my feelings. So I thank you for that. So my colleague Denise has already gone over the learning objectives for the whole session, so I will not reiterate those for you. Specifically, what I intend to review over the course of my talk is to provide to you an understanding of the background that led to the implementation of a measurement-based care system in Canadian Armed Forces mental health clinics. I hope to provide a description of CHROMUS, which is the measurement-based care tool used by the CAF. I will then give you an overview of the implementation progress to date. And then finally, I will identify some of the barriers to progress that we've identified in some of the limited research that we've done on the issue to date. So in response to deficiencies identified in the late 90s, the Canadian Armed Forces, since approximately the early 2000s, built an extensive mental health system that was designed to provide comprehensive outpatient mental health clinical care, peer support, rehabilitation, as well as an integrated mental health literacy program known as Road to Mental Readiness, or the abbreviation as it's well branded right now, R2MR. And that was originally designed as a primarily post-deployment educational program, but has now been designed to be present at every level through the career development, from basic training all the way through to attainment of senior ranks. So how has that implementation of that extensive system fared? Well, we've benefited from some state-of-the-art population-based mental health survey research that allowed an examination of the possible impacts of that system on critical elements of population mental health over the first decade of implementation. And in this slide, I provided you a few of the findings from that extensive body of research. So we saw that overall there was more care seeking amongst members of the Canadian Armed Forces over time, from the decade period between 2002 and 2013. And that would suggest that efforts to address structural barriers and perhaps some attitudinal barriers to care were being realized. However, we saw relatively little change in prevalence of mental disorder. If anything, PTSD prevalence doubled. Depression remained as high in the intervening decade, which is twice that of the Canadian general population. And anxiety also was seen to increase. Now, the causes of mental disorder are multiple and complex, as are the reasons for any observed lack of improvement. But it does really start to beg the question as to why. So after a decade of having implemented the mental health care system, were we really seeing the results as good as they could be? Can we do better? Prevention, of course, is a key target, but really, we lack effective tools to prevent mental health problems. We certainly don't understand the evolution of that well enough to begin to use targeted evidence-based interventions. We know that barriers persist and efforts to address that are ongoing. We absolutely require more effective mental health treatments. I think everyone recognizes that, and work is ongoing in that. But investment dollars into the research to date certainly hasn't been optimal to yield fruit on those endeavors. So one potential strategy, of course, is to use existing treatments more effectively. But how can that be achieved? Well, as my colleague has alluded to, and we're not the first to come up with this brilliant idea, measurement-based care is one potential avenue. Again, to reiterate, it's the practice of using routine symptom measurement to inform treatment. An optimal system would require that the measurement-based care program that was implemented at system level would have some key components. First and foremost, evidence that it works, that it can be used in a broad range of psychological issues and by a broad group of practitioners, which means that it would be trans-theoretical and trans-diagnostic. Now, the OQ45 system, at least in our assessment at the time that it was implemented, met that goal. So CHROMUS, as it's currently known within the Veterans Affairs system, which first adopted it, and we actually then subsequently implemented the identical program, it stands for Client Reported Outcome Management Information System. And many practitioners were already familiar with and using the core base element of that, which is the OQ45, which is, of course, transdiagnostic, and it contains 3 subscales. That includes symptom distress, interpersonal relations, and social roles. Now, the system developed by OQ Analyst actually has, beyond just this tool itself, built-in predictive algorithms to identify reliable change in scores from one treatment session to the other, or failure thereof, compared to a population-based reference database that they had developed over a vast range of clinical scenarios within the US. So that included outpatient systems as well as inpatient systems. And as I mentioned earlier, that system had already been implemented for about 2 years prior to the CAFLA implementation in Veterans Affairs Canada. So in this slide, I'm showing you what a sample output would be of ongoing treatment. Clinicians are provided these graphical displays after the patient has completed populating the OQ45. And it shows overall change or change in their overall score, as well as change in their subscores, session by session, as well as flags when the patient is failing to progress, which in the terminology of this system is a not on track patient, and it's compared to normative standards on a population-based data. So the not on track flag, if it is raised in any given clinical encounter where the OQ45 is completed, actually has, in addition to that, a built-in clinical support tool called an assessment for signal client. And that assessment for signal client tool, when completed, can provide the therapist some insights into potential reasons for lack of progress. And there was an extensive body of published evidence showing the value of utilizing this tool in the context of delivering psychotherapy. So based on that, the Canadian Armed Forces decided in 2014 to implement the CHROMUS system, or to procure it and implement it. And we immediately encountered barriers. So the first of that is that the members of the Canadian Armed Forces aren't veterans. And while veterans have served to protect the nation. They are not currently serving. And the security constraints in the CAF were quite unique. And that required retooling the platform so that it would not use a third-party cloud-based platform, i.e. the data did not reside external to national defense, and it wasn't housed by an independent third-party entity. And that itself had some challenges. So we did an initial pilot in our Ottawa clinic, which is the MOFOR, between November 2014 and March 2015. That pilot led to some retooling of the platform to resolve some of the cumbersome administrative issues. And there was a subsequent rollout of the new platform where the computer tablets where the OQ was completed were hardwired into a CAF-specific server available across CAF clinics. And then in 2020, the pandemic hit, and a hardwired system for delivering OQ45 turned out to be infeasible. And we then went on to a Chromis at-home system, which I can get into at some other point in time. So how did we fare? Well, I think the graph demonstrates it not terribly well. There was some initial uptake, but at closing, as of currently, we have about 54% in which the OQ45 is completed, and about 29% of those are actually viewed by the clinician. We attempted to understand barriers to care by doing a quantitative survey. Unfortunately, we only got a 23% response rate, which is a recurrent theme anytime we try to survey clinicians about any issue pertaining to patient treatment. But some of the overarching things that emanated about that was doubt that Chromis met the needs of the patients, that there was little incentive for staff to facilitate the use of Chromis. There was expressed concern about how the results would be used by clinical leaders. But most of all, I think the survey led us to believe that maybe the survey tool we used was not terribly the best tool to use. Now, in the interest of time, because it looks like I'm running out of it, all right, well, I guess I still have a few more minutes. There are well-published or Denise has already alluded to published evidence about drivers and barriers. And I've highlighted a few of these here. So, you know, we know that, that anywhere from 30 to 50% of patients in which measurements are done will show no reliable change at end of treatment, and about 10% will deteriorate. And to be honest with you, without the use of a measurement-based care system, we can't really state what the results within the Canadian Armed Forces Mental Health Clinic are in comparison. We know treatment dropouts reported in the literature about 40 to 60%. I can tell you some recent unpublished data we've looked at shows that in the CAF, it's probably around there. And we know RCT evidence suggests that measurement-based care tools have the potential to significantly reduce treatment failures, but in the absence of implementing this system in the CAF, we can't say whether it would have the same effect in our population. In terms of barriers, well, there's the practicality, there's the concern that the client will find it burdensome, and lack of confidence in how the data will actually be used or reliably interpreted. And I suspect many of those, as I've alluded to in my earlier slide, are also at play within our group. So in summary, you know, we do have a need for a measurement-based care system, and it remains as relevant today as it did when it was introduced in 2014. And despite varying efforts, adoption has fallen far short of the target. The research that we've done to date has shown some, but not all, the barriers, but it really hasn't revealed what the tipping point is to promote adoption. So I think at this point in time, our future endeavors need to include planned research as to how we could better understand barriers and drivers, as well as collaborate on implementation efforts between ourselves and other allied groups, such as our partners in Veterans Affairs Canada. And then my last slide is just to show you some references, and I thank you for your time, and I will now pass the floor to my next colleague.
Thank you, Brian. I'm Venkat. I'm a clinician scientist at the University of Toronto. That's my affiliations slide. My disclosure slide. Moving on, so I'm going to be talking about three specific things today. One is an overview of what is implementation science, why is implementation science needed, and then a summary of barriers and facilitators, which has already been mentioned, and then emerging role of some new digital modality. So I would like you to think of alternate ways of doing measurement. So a lot of the studies which have been shown are actually doing data capture through scales. And I would like you to think about what are other ways of doing this and give examples of what could be implementation challenges there. So implementation science is part of the knowledge translation framework. So this is a quick definition from the CIMVHR perspective of what is knowledge synthesis. And it's important to keep in mind that there's the explicit aspect or the codified aspect, which is what is mentioned there. But there's also the implicit, provider-based knowledge aspect, and these things go together. The knowledge, the experience within the individual, the provider, and the organization. So essentially, you're looking at accessing evidence, understanding the evidence, and benefiting from that evidence. So speaking about benefiting from evidence, there are different subcomponents within knowledge translation. And as was mentioned by Denise at the outset, there are different theories, models, and frameworks specifically for implementation within knowledge translation. This is the framework which Denise introduced, the Nielsen's framework of looking at the aim of the approach and then the key characteristics of the approach. So describing and or guiding research into the process, that is one, then understanding or explaining what influences implementation and outcomes, and then evaluating implementation. With some examples, I think it'll make things a bit more obvious. I'm not going to get into all the specifics of the various theories. That's a 1 hour discussion, but I hope to illustrate a few key things. It's also important to keep in mind that this is an relatively newer domain, and there are a lot of unanswered questions or ongoing work as to how to implement things. So what is implementation science? A systematic study of the process, factors, and mechanisms necessary for successful adoption of evidence-based interventions. The objective is to result in widespread use and uptake of new practice. And as was alluded to earlier, there are also standards for reporting implementation studies. What is often also mentioned, and this is encapsulated in some of the work which we are doing, is the effectiveness implementation model. Effectiveness is the type 1, implementation is type 2, and the hybrid approach of looking at effectiveness and implementation together. So I'm not going to go through this, but the point here is that we are not arguing that measurement-based care is necessary. And there are multiple examples here, beta blockers and aspirin. We know it works, but it's only prescribed in 60 and 30% of the population. The same with adoption of insecticide nets, and as you can see, for measurement-based care and mental health as well. So their application in real world is not what it should be, and we need to find out why and to try new approaches to change this situation. So that's in base, fundamentally why implementation science is needed. Implementation science outcomes are distinct from service outcomes and client outcomes. So you're looking at effects of activities, that includes things like adoption, appropriateness, feasibility, fidelity, and then you're measuring implementation outcomes in addition to client and system outcomes. So those are the differences which is important to keep in mind. Now I'm moving on to barriers and facilitators. This was mentioned before, but I'm going to just highlight a few key things as barriers which have been mentioned before in measurement-based care. So time, measures are designed more for research use than clinical use. Measures are not always clinically relevant. It goes on the perception that measures are more useful than clinical assessments, lack of protocols and training manuals, lack of incentives to use measurement-based care, lack of consensus as to which instrument to use. So these are general known barriers, but it's also important to actually individualize that to the particular patient and the clinician, the hospital, and the system. So taking knowledge translation and personalizing that to the individual hospital and system level is the implementation aspect. So that is how implementation science is being viewed within knowledge translation. So these are some of the facilitators to implementation. It needs to be efficient. Measures should be brief and not time-consuming. Measures should be reliable and valid, user-friendly, and the reflection of what clinicians would do in real practice. It needs to be brief, clinically meaningful, and useful, relevant to decision-making. One key aspect is also that it needs to be extractable and not embedded in progress notes, and sensitive to actually changes induced by medications or psychotherapy. So moving on, I'll now present some of the work we have done in this domain, and also position it for the next two talks in the context of how digital health interventions have been examined. So all of our projects, the ones which I'll be mentioning in the next couple of slides, are looking at process evaluation and outcome evaluation. So when I say process evaluation, I mean the context where you would look at monitoring changes. In the context of our projects, it was the post-pandemic status, peri-pandemic status, post-pandemic status, inputs, monitoring technological stakeholder end user needs, monitoring technologies being used. So that's on the process side. And then outcome evaluation includes things like implementation challenges, engagement, and impact on the individual and population level. There's a whole framework around engaging stakeholders that includes, it has three subcomponents: an organizational subcomponent, value subcomponent, and a practices subcomponent. So I'll just introduce the idea of digital health interventions and give examples of how we have done this in the clinical framework and also in the non-clinical framework with upcoming studies. So this is a broad term, and it includes guided and unguided. So unguided is self, and guided could be facilitated. It could be synchronous or it could be asynchronous. If it is synchronous, it is actually feedback given in real time. Asynchronous could be feedback which is actually provided, which is convenient for the person. It could be by email or by text. It could be interactive, where there's use of conversational agents such as chatbots. When you look at predefined cutoffs, that information is actually relayed back to the provider or back to the participant or the patient. This is an emerging domain, and I'll give some examples of how we have tried to incorporate this. This is a slide, this is upcoming work looking at consideration for implementing digital health interventions. So I would encourage you to look at the left-hand side, which will be pertinent, not the right-hand side, which we can get into later during the discussion period. Is it effective? Is it secure? Are there risks? Does my patient have access? And is it engaging? These are some key components with respect to implementing digital health interventions. So the next couple of slides is going to be real visuals. I'm not going to get into the details of any of them, but to give you a sense of how we are doing this work. So we have a multi-institutional group. We're looking at clinical populations, and we're also looking at non-clinical populations. We have tried to do measurement through not only the scales and apps, but also to use virtual reality apps and wearables to do measurement. So when you speak about measurement-based care and measurement in care, I'm presenting alternate ways of actually doing measurement. So this includes VR simulation, web-based platforms, and wearable devices. We've really used a 4P medicine approach of prevention, predictive, personalized, participatory medicine. And we've also looked at measurement where people are exposed to a virtual rendering of a real scenario before they're actually in that scenario. So it is a step forward in terms of predicting how the person would actually respond in that scenario, even before they're there. So this is the program we have developed at St. Mike's with the 3 components. This is how it comes together. And I would like you to focus on how we've worked on implementing and trying to understand the barriers and facilitators to implementation in a clinical framework. So we have people with treatment-resistant depression who cycle through different emerging treatment modalities, and we do app-based, wearable-based data capture in this clinical context. So this is a clinical example. The next couple of slides, and then I'll stop, is the non-clinical population where we're actually doing this kind of work. This is work with, funded through the IDEAS program, where, as I mentioned, we're using the same 3 VR app wearable-based framework to actually understand to measure stress responses. So this work is just being completed with 100 participants who have gone through the paradigm. This is an example for healthcare providers. We have a project which is just being launched, looking at other populations and also looking at barriers and facilitators in the international context in Canada and in Brazil. This is a study which we are particularly excited about, funded through the National Research Council, looking at digital interventions and implementation barriers in Canada's north. So we're looking at the province of Labrador here. So there are almost 12 communities or so along the eastern seaboard, and the physician has to fly from Goose Bay, which is the only regional hospital, to these communities every month or 2. So we're doing remote measurement-based care in these communities. So this is a 3-year project, which is just starting working with the Indigenous community there. So this is the network of our partners, our funding bodies. So I'll end by summarizing what I've gone over. What is implementation science? Why implementation science is needed in measurement-based care? I've gone over some of the frameworks there, the barriers and facilitators, and I've also mentioned about looking at measurement through alternate modalities. So with that, I'll stop. Thank you.
Hey, good afternoon. My name is Pam Hollins, and I'm what the heck am I? I don't know. I'm just a person standing here. I'm a clinical psychologist, and I've been working at the Operational Stress Injury Clinic at Deer Lodge Center here in Winnipeg for almost 14 years, since the fall of 2010. And I'll just tell you a little bit about that clinic. It opened in 2004. And as I said, I started working there in 2010. And I just want to give some kudos to the folks that were there at the beginning of the clinic. They saw in advance the importance of measurement-based care. And so it was just part of the system that I walked into, where it was just assumed that we were doing measurement-based care. And I think that that has had a huge impact on me as a clinician. And I think it's been great. So back then, what we were doing is every 3 months, folks would get a series of questionnaires. One of them was about PTSD, one was about depression, and another was about anxiety. And every 3 months, we'd check in and see where folks were at, and we'd create a graph and show it to the clients to let them know where things are at. More recently, we have switched to the program that was talked about earlier, CHROMUS, with the OQ45 measure. And that one we're tending to do pretty much session by session. But anyway, that's sort of my background, is sort of coming into this system where measurement was done on a regular basis. And so I came in as somebody who had a little bit of knowledge about chronic pain. And so I started up some pain programs. And of course, we need to measure pain as well. And it's measured a little bit differently. I forgot to do this first before I started talking too much, but here's my disclosure. There really is nothing to disclose. I don't make any money outside of my salary. These are the things that I want to talk about today. So I'm hoping that by the time I get finished with my talk, you'll be able to identify several of the well-researched self-report measures for chronic pain populations and be able to sort of compare and contrast the type of information that's offered by each of them, and then describe how the use of these self-report pain measures has changed the nature of chronic pain treatments that are offered at the clinic where I work, because it has had quite an impact on the way I look at things. I just wanted to start with briefly talking about this article from the Association for Psychological Science about psychological interventions for the treatment of chronic pain in adults. And this was an article that came out in 2021, and it had a fairly profound effect on me in terms of some of the messages in here. And one of the messages was that maybe we shouldn't even be talking about this as pain management anymore. We should be talking about it as pain treatment. So I'm trying as much as possible to use that word rather than pain management. And that connects a little bit with what I'll tell you about my path at the OSI clinic with the different treatments. Another thing that I wanted to highlight is from the article, and if you work in the field of pain management, you've probably seen this diagram many times, but recognizing the fact that pain isn't just a sensory sensation. There's so much more to it. It's big. It involves all kinds of different systems, the biological, the psychological, the social. So if we're going to measure chronic pain, there's probably more to it than just, how bad is your pain on a scale from 0 to 10. If we really want to get a sense of what's going on, we probably need to look at it from a number of different angles. So I'm going to talk about some of the angles by which I have measured chronic pain. Oh, that's just another plug for psychology. It's from the same article that I started with, which, by the way, I'll end with as well. But just talking about the effectiveness of psychological interventions in the management of chronic pain or the treatment of chronic pain and some gaps and so forth. But a plug for the importance of psychology in the field of chronic pain. Okay, so one of the measures that I use that is quite well established is the McGill Pain Questionnaire, or the short form McGill Pain Questionnaire. A lot of these questionnaires have had some different variations over the years. So I use the shorter form. It's a multidimensional measure of perceived pain, typically used with adults with chronic pain. It looks at both the intensity of the pain and the quality of the pain, using a series of words to describe pain. So there are 15 words on this particular version. 11 of them are more sensory in nature, and 4 of them are more affective in nature. And for each one of those items, a person could score anywhere from 0, none, sorry, that says no one, it should say none, to mild, to moderate, to severe. And you can have a score on the range from 0 to 45, higher is worse pain. And the minimal clinically important difference is about 5 points. So, about a 10-point change in these measures indicates there's something going on. Just to give you a little look at what the questionnaire looks like. I know that's probably a bit small, but a list of words that the client rates, as I said, from none to mild to moderate to severe. There's also a visual analog scale where they can just say, right now, how bad is my pain? Mark an X on the line from not at all to very, or no pain to worst possible. And then another scale for current pain, just using one word to describe it. So that's one thing. And this I think of as, out of the measures I use, the one that measures the intensity of their pain. How bad is your pain? But like I said at the beginning, there's a lot more to this than just, how bad is your pain? So another thing that we can look at is, how much is the person accepting of their pain? There's quite a large research base about a type of treatment called acceptance and commitment therapy for chronic pain, as there is for CBT for chronic pain. And so if one is using the ACT approach, acceptance and commitment therapy, one might be very interested in looking at, well, how much is acceptance of the situation actually helping the person? So there's different subscales. How much are you engaging in activities? How much are you sort of willing to do things despite the pain? It's a little more complex to use because there's some reverse scored items. It's got a range of 0, never true, to 6, always true, a scale, and then ranges up to 120. Higher scores are better. This is also one of the unique things about this measure, that in the other measures, you want to see the scores go down. This is one where you want to see the score go up. So if you're using this one, you kind of also have to be aware of that. And, about a 12-point change would be clinically significant. And here's a little bit of what that would look like. So a couple of the questions. I'm getting on with the business of living no matter what my level of pain is, or keeping my pain level under control takes first priority whenever I'm doing something. So another way of looking at things. Pain catastrophizing is another way to look at it. How much am I seeing this as horrible, a disaster, the worst thing ever? It's only going to get worse. So, how much of an exaggerated negative orientation towards the pain does the person have? And how much does that impact their ability to cope? So again, it's got a number of statements. There's 13 of them. Got a range of, or a scale from 0, not at all, to 4 all the time. A range of 52, about a 5-point change is important. And here's a little look at what that might look like. So statements like, I worry all the time whether the pain will end. I feel I can't go on. It's terrible, and I think it's never going to get any better. This one, I didn't start using this one, but I decided very quickly that this is kind of important too, the Pain Disability Index. So, not only do we need to know how much pain I'm feeling and how, worried I am about it or how accepting I am of it, but how much is it actually impacting my life? How much is it sort of disabling me? So this measure looks at a number of different areas in one's life that could be impacted by pain. So your family and home, recreational activities, social activities, occupation, sexual activities, self-care, life support activities. And this one, we go from 0 to 10 and can get up to a score of 70. And it kind of looks like that. And one more that I use typically is the Tampa scale of kinesiophobia. So this is a big word that essentially means fear of movement, fear that, if I get too active, I'm going to exacerbate my pain and make the situation worse. And there's I'm going a little faster now because I saw the time thing. So the long and short of that is I started at the OSI clinic doing primarily an acceptance-based treatment. It had a little bit of a CBT flavor to it. So I called it an acceptance-based behavioral treatment. And this is an article that was published in this lovely journal, some of you may know, that was just a small scale study, a pilot study of an online version of this treatment that I had created. And I want to just show you some of the results here because this kind of had an impact on me. The Cohen's D, the effect size on the right-hand side, you see for acceptance, that's a really big effect size, 1.49. That's quite large. So acceptance-based therapy causes people to really feel much more accepting of their situation. But I also got quite dejected when I looked at pain intensity, and maybe I shouldn't have, because the Cohen's D is 0.42, which is, small to moderate-ish. Not bad, but I guess in comparison, it didn't look so great to me. So I kind of, at that point in my career, thought, well, this is about pain management. It's not about changing pain. Pain doesn't change that much in terms of intensity. And in fact, I then took on a student and we did a randomized controlled trial and of the same intervention. And we didn't even measure pain intensity because I thought, well, what's the point? I mean, pain interventions don't help with that. Wish I had now, going back. You learn a lot along the way. But anyway, we did see that, compared to a control group, the people in the study itself with the treatment measure did better over time. And a number of the measures improved, particularly the pain acceptance. Then a few years ago, because I was not satisfied, I did not like the fact that I wasn't having a huge impact on their pain, or at least I didn't think so. I actually had stopped measuring it. So, but that was my sense that this treatment was not really helping people feel a whole heck of a lot better in terms of feeling less pain. They were just saying, it doesn't bother me as much. I'm more okay with it now, but it still hurts like, what? Anyway, so I was looking for other things, other ways to approach it. And I'm going to show my second visual here. I came across this book, Unlearn Your Pain. And it takes a different approach. It's kind of very science-based, and it talks a lot about what's going on in the nervous system and how, in essence, when people develop chronic conditions like chronic pain, their nervous system has learned that response, and it gets stronger and stronger and stronger over time. But we can unlearn it. So that was kind of fascinating to me. And I ended up publishing some data about the effects of that, and a little bit better in terms of the total pain intensity change, the score right on the top there, the under the D there, that's your amount of change. And it was 0.71, so better than the 0.4 or something in the previous study. But then what was even more interesting, because the Journal of Military, Veteran and Family Health is a really good journal. They have good reviewers. And the reviewers said, what about follow-up data? This is all interesting, but did you do any follow-up with folks? And I really hadn't been doing much of that, but I did have one group that I had called back a bit later and asked them to do the measures again 8 weeks later. And this was really fascinating to me. They kept getting better. Their change in their pain intensity was even greater at this point. So you can see the effect size there right at the top is 1.37. So I started getting really excited about this as an approach to pain. Since then, something called pain reprocessing therapy has come out. It's sort of an offshoot of this that adds in another component, and I'm using that, and I think getting great results. I haven't published anything yet. There's 1 minute left. Okay, I will quickly, wasn't sure if I'd had time for this or not, but there was a study done that was a really great randomized controlled trial where they compared pain reprocessing therapy to a placebo and usual care. And they had roughly about 50 people in each group. And the main focus of the treatment is reappraising the pain as due to non-dangerous central nervous system processes. And this is just a little bit about the whole setup of it. But the important thing here is that 66% of the people that were randomized to the treatment group were pain-free or nearly pain-free at post-treatment, as compared to smaller percentages, 20% in the placebo group and 10 in the usual care group. So that's pretty amazing to be able to be at the point of pain-free or nearly pain-free. So it's had a huge impact on me being able to look at what I'm measuring and see, what's changing. And that's caused me to change the treatment approaches I use. And I think as a result, I am doing a treatment now that certainly works better for me as a clinician, and I think works better for my patients as well. And I think that's about it. So thank you very much for your time. And next we have Anne.
Bonjour, bon après-midi. Ça me fait vraiment plaisir d'être ici. C'est très, très rare que je peux commencer une présentation par le français. Donc, et c'est aussi loin que ça va aller parce que je suis incapable de présenter la science en français. Donc, switch to English. My name is Anne Germain. I'm the founder and CEO of Noctum Health. We're a digital health company creating and validating clinical decision support platforms for remote patient monitoring, really in the sphere of behavioral sleep medicine. And I don't know why it's not. There. All right. So this is me. And those are my conflicts. So I already mentioned that I'm the CEO. I'm also an employee. I have equity in the company that creates COAST, a clinical decision support platform that you'll see this afternoon. I also have a disclaimer because some of the data that you'll show here is actually from studies that were funded by the U.S. Department of Defense, the Army, Navy, or Air Force, depending on the data set. So I have to say that the data and the opinions here are mine and mine only, not representative of the U.S. government, where I now live. And for mitigation of my conflict of interest, well, I guess I'm here because I know a thing or two about sleep and PTSD. I've been in this area for 25 years, but I will not use the opportunity for marketing the product. I promise I'll use it as an example only. And when I do mention what we do in the company, you'll see a star on this slide. I will mention it. So take what I say critically as good judges that you can be. And I added some references there to that you can consult to verify that what I say about the evidence-based treatments that we have in behavioral sleep medicine is actually consistent with the professional associations that have established these treatments. So I'm going to skip this. I'm really, you've heard a lot already about the first two objectives. I want to focus my time on using measurement-based care specifically for the treatment of insomnia comorbid with PTSD. And actually what I should have said is that my biggest conflict of interest is I'm a sleep person through and through. So I'm going to try to convince you that sleep is really important, that you need to measure it and that you can treat it. So that's my biggest conflict. That's the one thing I'll try to push today. Because sleep is really a pillar when it comes to health, resilience, and readiness in not just military occupations, but public safety, public services, generally speaking. And what you see there is really a summary of what sleep has been shown to be important. It's really a fundamental biological function that supports a number of other functions that are key to successful daytime well-being and functioning. And any kind of sleep disruption because of stress, because of other reasons, because of shift work, for example, any kind of factor that can disrupt sleep, and exogenous or endogenous, is going to have a direct impact on any of these functions. And on the macro level, what we see is the multiple impacts that poor sleep has on health, functioning, readiness, and resilience. I've depicted a few on this slide here. We know that there's a very strong association between sleep and obesity and cardiovascular disease. I'll show you examples of how actually poor sleep is one of the strongest predictor of vulnerability to develop PTSD, depression, anxiety, chronic pain. In military populations, we know that sleep problems are actually associated with early separation, with injury, with poor performance on all sorts of military relevant tasks, with pretty significant accident. What you see here is the USS McCain, where because of fatigue, there were human errors that cost many lives. Injuries, either poor decision-making, risk-taking, that's a car accident that you see there for different reasons. So all of these have been related to poor sleep, including all-cause mortality. So really, sleep is not only just a pillar of health, resilience, and readiness, but I'll try to convince you that it is a target that can be measured to drive care specifically for sleep. And this is really a summary of like 25 years of literature, including some of my own studies at the University of Pittsburgh. But there's this very strong relationship between sleep and psychiatric outcomes or psychological health, if you want. We know that people who are exposed to a traumatic event and develop insomnia, so problems falling asleep, staying asleep that lasts for more than 3 months, are at much higher risk of developing chronic PTSD. But it's also true that I have to stop doing this, the other conditions that are listed there. But we also know that people who have poor sleep prior to experiencing a potentially traumatic event are also more likely not just to develop chronic insomnia, but then to develop PTSD or other kinds of psychiatric disorders. And actually, Dr. Afifi this morning talked about childhood exposure. Childhood exposure in combination with poor sleep is also one of the risk factors for adult PTSD in service members, but I would imagine that it's true in other populations. Now, alternatively, there are also studies, or some of these same studies shows that people after exposure to traumatic event who can go back to normal sleep within a few weeks to a few months, are the ones who are most likely to recover, to show accelerated recovery, to show going back to a baseline or a new baseline, but are the least likely, if you want, to have the chronic adverse effects of both sleep problems and trauma exposure. So what it tells us is that insomnia or sleep more generally offers two targets that we can target, not to be redundant, but two specific areas that we can treat with our evidence-based treatments. And in the context of insomnia, that's cognitive behavioral therapy for insomnia or CBTI. And what I want to do next is really take that as an example of how we can use measurement-based care for not just measuring improvements in sleep with treatment before and after, but in the process of making these decisions, in evaluating how we can really have achieve high standardization of care without compromising the precision and the personalization of care for each patient. Been in or indirectly from what engaged in measurement-based care for insomnia for a long time. In 2015, I was part of the AASM task force on identifying quality measures for the treatment of insomnia. There were a lot of us on this task force, had a ton of discussions of how we should measure insomnia, not just like before and after treatment, but how do we determine the quality of insomnia care that people have. And we thought, we'll use our very well validated and reliable measures, so sleep diaries, validated self-report questionnaires that we have. And that kind of backfired a little bit when we tested it or asked clinics to test it. Really, what we realized is that the good ideas are really hard to implement in the front line in the clinic. A questionnaire seems simple, give the form, get the form back, score it, make a decision. But this whole process is not necessarily something that is seamless in a busy clinical, real world clinical setting. So we actually recommended two things. One is ask people how their sleep is. And then when you see them again over the course of treatment, ask them if they think that their daytime functioning is improving. So we really had to simmer it down. But it's not because the measure was simmered down that it wasn't good, that they weren't good measures. They were doable measures that could still inform clinical care in insomnia. Otherwise, the process that is outlined there is the same process that we all do in treatment. We measure, we match the treatment, we monitor, we modify accordingly, we adjust, we remonitor, remeasure, continue until we achieve the desired outcome and maintain. So what does it look like with CBTI? Well, it's complicated. Don't read through this. It's just an example of how in the evidence-based treatment or CBTI measurements is built in, right? We'll use scales. We use our preferred tool is really a sleep log, but that requires a lot of time. What you see there is actually, as I said, the protocolized version where you have one clinician, one patient who has 45 minutes each week for 8 weeks to take about a third of that session going through the measures that were collected. In regular care, where the assets or the medical personnel is limited, where people come with a number of comorbidities and sleep is just one of the complaints or one of the challenges that needs to be addressed, that can be really challenging to do this. So really, we need to not only have methods that allow for scalable measurement-based care of insomnia, but also to be able to have scalable evidence-based treatments to address all of these issues that are identified with all the measurements that we're doing. And that's an example, like you can use, you see the Insomnia Severity Index, the ISI there, normal score is below 7. So we can use questionnaires, we all do. But if you see a profile like this, many of you in the room probably think this person likely to have PTSD. I see this and I'm thinking, I'm going after the sleep and the nightmares, the insomnia and the nightmares to get from. So it gives a pictures of what the challenge is, maybe, but not necessarily the specific targets. We can take a closer look and just look at macro structurally for sleep. What does sleep look like in terms of how much they sleep versus how fragmented or consolidated sleep is? Or we can really take a more micro level approach and look on a day-to-day basis. What does people sleep like when we look at how long it takes them to fall asleep, that's sleep latency, wake time after sleep onset, how long you're awake at night, how many nightmares people have. But what you see there is that if you do this high precision of measurement, that you have daytime or daily measurements, then you have to have a way to be able to synthesize that information and extract what's meaningful so that clinician can really quickly make the decision that they need to make, personalize the treatments, the techniques that they want to use for this individual patient. So what we have done, and this is like my conflict of interest kicking it here, what we've done is try to address these challenges and create basically a software platform. It's a clinical decision support platform that allows clinician actually, I should rephrase it, that allows the technology to do what technology is really good at: collect the data, summarize it, synthesize it, present it in a way that is easy to read, and let the clinician use that data to make what I don't think technology can do is a good clinical decision for that is really particular to a given patient. So this is what it's called COAST, and it stands for Clinician Operated Assistive Sleep Technology. It has a component really centered around the clinician, a digital, really a cloud-based platform that allows the clinicians to monitor patients remotely, asynchronously, in 5 to 10 minutes per week, because all this information is already collected from the patients. And we've built in the algorithms that match the patient sleep profile with the evidence-based sleep treatment. So we make recommendation the software makes recommendation to the clinicians saying, based on the information that can be interpreted by technology, here's what you should recommend, you could recommend to this person. Put my hands behind my back. But ultimately, it's up to the clinician to decide what they want to do and if they agree or disagree. So actually, I should just make it faster here. So there's the clinician portal, the patient app to consolidate, to collect the data, to make sure that the data is error-free and that it's transferred in real time to the clinician so that it's available on demand when it's time for the clinician to review the information. So what I want to show you to finish here is this quick example of how this applies. This is a real example of Matt was a 30-year-old Marine that we saw early on, who came with nightmares and insomnia, had just been diagnosed with post-traumatic stress disorder when we saw him, or 6 months before, was on a wait list for treatment, and had been in treatment for chronic concussive symptoms for over 1.5 years. He had like a number of deployments in Iraq and Afghanistan, came and we basically used the platform with him to monitor remotely asynchronously. And what you see there is progress over time in sleep latency, or SL, and wake time after sleep onset. And what you see is that very quickly, and this is not atypical, where we can measure on a day-to-day basis, have the average for a week of what sleep looks like, provide what you see, those little green circles at the beginning, at the bottom there, that are too small to read, really, are basically the specific technique that were adapted for this individual person on that week. So what kind of behavioral modifications were recommended on that week? And not only can we measure the sleep latency and wake time after sleep onset, but that's where I think digital measurement-based care is really important, is because we can also measure whether they do it or not, the engagement and the engagement of the clinicians. Did the clinicians recommend when they were supposed to make those recommendations? And you can see that iteratively, this measurement repeated with adjustments of recommendations lead to really quickly being within normal range when it gets to these sleep parameters, but that these improvements are sustained over time. This is something that you would capture pre and post treatment or over time on these different scales. You've seen those before. This is his profile from baseline to post treatment and 2 years later, but that's actually replicable at scale. So another conflict of interest slide here, when we compare what we see, there was like about 500 people who receive the treatment through the platform. How does the treatment of comorbid insomnia with clinical decision support platform and digital measurement-based care for insomnia compares relative to the face-to-face CBTI traditional treatment, or to the most common treatment of insomnia, that is really medication for comorbid, complicated and severe insomnia? So summary, I'll just go to the last couple of points, is that I think we think of measurement-based care oftentimes in measuring symptoms. I want to make sure that we don't miss the opportunity to also measure engagement, adoption by clinician, patient engagement, clinician engagement, and that process of back and forth that goes to be able to continue to refine, especially if we talk about AI. We need to be able to capture that data to have AI that actually behaves almost like a clinician. So I think there's a number of opportunities for measurement beyond symptoms that we should capture. And then I understand, I've had this experience myself too, that we think of measurement-based care as it's going to give me more work. But actually, when it's well implemented, I think it can decrease the burden for both the patients, the clinicians, and ultimately the system. And I'm out of time, so I will stop talking now. Thank you.
So I think that's a new record. We've had 5 speakers that all, stuck to their times and didn't go over. And that's why it's so important to practice the number of times that we did, right, guys? I mean, so Sarah, can we take a break? 10-minute break? Okay, 10-minute break. And we're going to reconvene sort of as a panel. The folks are going to be up here. There's questions. Because things are being recorded and they're on sort of Zoom, so everybody please, we'll distribute mics and stuff. So make sure that we do that. We have a bunch of questions online. I think we're going to give our online people. I think Brian Garber got the record number of questions, including where do you get your suits and things like that, Brian, the usual stuff. So let's take a 10-minute break and then we'll reconvene. Okay, folks, welcome back after the break. And we're going to start with a few questions for the panel. Of course, I'm sure the panelists have questions for each other, but let's we're going to start with Dr. Belanger, Stephanie, because she's been tracking the online discussion, and maybe we'll start with a couple of questions from the field.
Okay. Okay. Nope. Is it working?
I don't think we hear you.
No one hears me.
Check, check.
Check.
It's fixed.
Okay.
The microphone needs to be connected.
Closer.
There you go.
Closer.
Or you can start beating it up like Anne.
Yeah, I can. Yeah, there's a bit of a French thing with the movements, right? So I have a question for Dr. Fikretoglou. Oh my goodness. Sorry, Denise. For Denise. Fikretoglou, there you go. How do you anticipate the use of measurement-based care during military to civilian transition? This may be important as military members with serious mental health issues are more likely to be medically released. In Canada, active military have different health systems support than veterans.
So what an excellent question, and very difficult to answer because, as I mentioned in my presentation, when we look at the implementation of measurement-based care in the veteran healthcare system in Canada, it's been less than optimal. When we look at it within DND, it's been less than optimal. And now we are talking about coordinating the two as people transition from military to civilian life. It's something that we do need to think about and plan for. I am not sure that we are there yet because independently, the two systems are not doing it at the level that we would like to see it being done at.
Yeah.
I don't know if
I can make a brief
yeah,
comment.
yeah.
O'Brien's going to have some thoughts on that.
Yeah.
But if you think about it, I mean, again, the good idea fairy, that's kind of why in the CAF, we picked the same model, right? Veterans Affairs had Chromis. So as we were looking for different models, we said, why not use Chromis as well so that we could share the data and have people have that sort of soft handout from the CAF to VAC. And that was the intention all along. And I don't think we've abandoned that. And to be honest with you, things have improved a great deal in terms of that transition piece, but more could be done. Brian?
No, I was going to actually say exactly what you said, that one of the key elements for the selection of the Chromis OQ analyst system was that VAC had already implemented it. And for individuals who are releasing because of a mental health problem, who would almost certainly be eligible to transition into the VAC system of care, that would help facilitate continuity of care. So I do think it's an important component. I recognize that if somebody releases and moves into a completely civilian setting of care where there's not involvement of VAC, that does represent a problem because, let's face it, we're unique in the sense that we actually have a mental health system for the military, and then there is a mental health system of care for people who are eligible in the VAC system. But if we move into the civilian setting outside of hospital-based care, that doesn't exist in an ambulatory setting.
Yeah.
So there would be a gap there. But yes, primarily the choice was meant to enable continuity.
Yeah, just connected to that, working in an operational stress injury clinic, I don't know if they're necessarily all the same, but the one in Winnipeg, we see active serving military
most
as
do.
well as veterans. So we often are with them while they are in the service and then as they transition out. So we
Yeah.
have the data going right through.
Sure,
Yeah.
that's a
so-
good point, and that happens across the country.
Yeah, okay.
Let's do one more online, then we'll do it in person.
A question for Dr. Garber. Other than MBC, what other strategies might policymakers consider for treatment of mental health disorders?
Well, MBC is just simply one tool, but it's an important tool in the sense of when it comes to effectiveness of any clinical intervention, you actually, I mean, you need to have some way of measuring that. For example, right now we're undertaking a small pilot randomized control trial of accelerated resolution therapy, which some people might be familiar with for treatment of PTSD, and comparing that with treatment as usual. And of course, like any other RCT, we're going to use some systematic measurement to evaluate whether or not that treatment has the intended benefit. But, when you look at other conventional treatments for PTSD, a lot of the literature is in non-military settings. And when you look into a military setting, you realize that very few people have PTSD alone. Oftentimes people have multiple comorbid illnesses. So what you see in the literature in terms of the benefit of a therapy may not translate to your own patient population because your patient population is very different. In order to understand how effective treatments are on a system level, there needs to be some consistent way to measure that. If we're to implement a new intervention, for example, accelerated resolution therapy, or other types of treatments that are evolving and coming to light, there needs to be some way to demonstrate the benefit of it. So I think the short answer to that question is I don't really have a good answer. Clearly, there are a lot of new emerging technologies that are that need to be explored. But one of the key ones is, and I think the talk by Anne touched on it, the concept of personalized medicine, which more and more people are beginning to understand. In order to personalize and tailor the treatments, you need to understand what's unique about that individual compared to others. And unless you capture that in some systematic way, I don't think it's going to be realized. I don't know if anyone else has something to add on that.
Well, Brian, I mean, I'll speak and then Ben can go. I mean, I think this is a great question, touched on lots of things. I think one of the purposes in the measurement case, so you have these DAW moments every once in a while, and one of the things I was speaking to some of the colleagues the other day is that, like, one of the reasons maybe that the real clinical care never measures up to the studies may actually be because the studies are doing measurement-based care. Right? The actual measurement itself, which we consider not part of the intervention, but we consider it part of the, measurement of the efficacy, actually every single week asks the patient to think about their symptoms, to think about their sleep, their energy, their concentration. So maybe the measurement during our study is an actual intervention itself. And so that's kind of, strengthens that. The other point is every one of our clinical practice guidelines, whether it's for medication care or changes, has inflection points. Like, why am I going to augment? Why am I going to change? Why am I going to do a different therapy? And if we're not measuring it consistently, how are we making those decisions? And I think if we make a decision that, hey, I think it's time for us to consider adding X, Y, Z, then you can sit there and talk to the patient and say, the last 3 weeks, nothing's budged. This is why I'm suggesting this. So I just think patient engagement, and I just think that for our trials, the actual measuring we're doing in trials is an actual intervention. It's not just our way of measuring it. So just my thoughts. And Venkat, please.
Yeah, I would just, add to that, it's key to look at the individual, organizational, and the system level barriers. As Brian was mentioning, it's key to look at the specific disorder and the comorbidities as well. So what may work for depression may not work when people have comorbid PTSD and substance use disorder. That is one aspect. And then there's also the
And sleep problems.
Yeah, the sleep issues for sure. And pain. So, it's also modality specific. What may work for psychotherapy may not work for behavioral intervention, may not work for pharmacotherapy. And depending upon the nature of the intervention, you would also need to look into the specifics. I think one key aspect is also looking at what, just as we were discussing about what the clinician wants in terms of adopting them into their care, what the patient wants. Often people want to have access to their own data. And when people see that, measurement-based care, and for example, if you're looking at sleep and, they see that the sleep intervention is leading to them sleeping better, that has a powerful reason for them to actually continue doing the scales and be involved in care. Also, last point I would make is it's important to not make a one-size-fits-all approach. Like you can start off scales regularly for acute management, and then once you go over the acute phase, for the maintenance phase rather, you don't need to do the scales as often. The scores really don't change as much. You can do the scales a lot less often. You can use shorter scales. So that's just important to keep in mind to customize with what patients would want.
And did you want to say something? We can take one question from within the room if somebody has one, and Sarah has a mic, but Anne, you carry on. Yeah, and you answer your question. You first.
Okay, yeah, just a few quick points
no.
to the point about the frequency or the type of assessments. There are adaptive assessments, computerized adaptive assessments that have been validated that are really good, where you can, if you can get the information that you need with 1 or 2 items, that's it. But if you need 35 questions to get to very precise type of measurement, that's also an option. So utilizing these kinds of, or starting to implement these kinds of adaptive tests that are valid and reliable can be a way to get to that precision and to improve the predictions and the personalization of care. And then I would caution, and I always do, so don't take it personally, but the idea that like in certain populations are different from others, and comorbidities can prevent using treatments that work for one populations. People are, in my mind, it's like, we don't know. So why not use what we do know to see how far we can take them, and then see in the context of comorbidity with sleep or with PTSD, with depression, with anxiety, suicidality, that see like what's the best treatment to start with. We need to start somewhere, and we should start with the messy group of people that don't come with just 1 or 2 conditions. And because the reality is, to your point, patients come with all sorts of complicated conditions, and we can't treat them all one after the other. And but we can't also withhold, be too risk averse to not take the chance that, well, there's a fair chance that we can help them one way or another. So pushing through. And I would say sleep is a good place to start, because I said I have a conflict of interest. I'll push sleep.
Any questions? Anybody in the room have a question? Should we carry on with the online? Was there one over there? No? Okay, let's carry on with the online. And
Okay, again for Dr. Garber. Is it OQ45 is fairly long, and if used at every session may well be a significant burden for patients, as there have been consideration of shorter outcome measures for regular use.
Yeah, I think that that is recognized, that having a person do 45 questions is a response burden on individuals. That said, in the limited times that we've surveyed patients, and we did do this at the time of the MOFOR clinic, that wasn't actually expressed by the people who surveyed them. So there is a little bit of a disconnect between some of the feedback that some clinicians get from their patients and some of the feedback that the patients have given directly. That said, I think that point is, it's a reasonable one. What I would say is that, one of the things that as an organization we tend to do is select a system and rigidly stick to it. So if there's a better system out there in the intervening period that was developed that fits the criteria that can be looked at as an alternative, I think that as an organization, we need to be we're ready and willing to do that. The other point that I'll make, which I didn't raise in my talk, is that a lot of people in our system prior to the implementation of Chromis were using OQ45 paper and pencil version. So there were a lot of clinicians who felt that the OQ45 was a perfectly acceptable way to measure patient progress. I recognize that the OQ Analyst platform is all geared around OQ45. The predictive analytics are all geared around OQ45. But the Chromis system also has other tools available. So for instance, it has PHQ, it has GAD so PHQ for depression, GAD for anxiety, is PCL for PTSD. Those are much shorter in length. They're certainly not 45 questions. They're probably closer to 10 in total, some of them. And we looked at the utilization of PCL sequentially, i.e. more than one time for people getting treated for PTSD. We found the vast majority of people getting treated for PTSD have a PCL 1 or 2 times over the course of the treatment. Similarly, patients getting treated for depression, we looked at the use of the PHQ, or the other one is the Beck Depression Inventory. And again, in those instances, the vast majority of people were getting those tools 1 or 2 times over the course of treatment. So I acknowledge that the OQ45 is long, but I think the length of the questionnaire is not the entirety explanation for why people are not using measurement-based care.
Anybody else?
Okay.
Oh, Denise, go ahead.
So I can add to that a little bit, and I would just echo that some of what Brian is saying about the DND experience is basically what we see in the broader scientific literature as well when we look at patient concerns and patient perspectives around measurement-based care. One of the leading concerns is that it's typically commonly not explained to patients why we are doing measurement. And if you ask the patients, they say that if you explain it to me in terms of how this is going to be helpful for my treatment, then I'm perfectly fine with it. But their complaint when we ask them is that we are not explaining it well. So that kind of goes along with what Brian said. The other thing that I will mention, kind of going back to the experience of our colleagues in the US, the US VA system, they don't use the OQ45 here. They use 3 or 4 measures, one of them being the PHQ. So much, much shorter. And again, you see the same implementation challenges, right? So it's not just the length of the measure. It is a valid concern. It can't be so lengthy if it doesn't need to be. Kind of going back to what other people were also saying. So when you look at the broader scientific literature, and I would say that we need to do a lot more research on patient perspectives. There's very little out there in terms of patient perspectives around measurement-based care. But what there is, if you look at that literature, you'll see that the patients are concerned about it being explained to them why we are doing what we are doing. And if we explain it well, if it makes sense to them, they are willing to do it.
Yeah, and I think that's really well put, because it's the patient-clinician dyad at that level, right? Because I think that when you hear sometimes, again, different sort of various complaints, sometimes the complaint is, back in the old days, I sat in the waiting room, I filled out 10 questionnaires, tried to think really seriously back to how I slept 3 weeks ago, 2 weeks ago. Then I walked in, I saw the doctor, gave it to them, they put it to the side and started the session, right? So you immediately invalidate the purpose of it, this kind of thing, versus do it ahead of time, score it, turn the screen over, say, this is why we're doing this. And the same way you would for you know, for cholesterol or for diabetes, right? You would look at the results together and say it's working, it's not working, this kind of idea. So I do think there is a bit of both have to be committed on the same page, I think. And next.
Dr. Garber, given barriers for MBC implementation, what efforts have been made to reduce barriers? Is policy recommendation required to move MBC implementation research forward? What might those policy recommendations be?
Yeah, that's a great question. Hopefully you have some of the answers that I don't. I think that so as I alluded to in my talk, you know, I think that it behooves us, anybody, to, you know, coin that phrase, try to work smarter and not harder. And I think that whatever policies we decide to implement should be based on better information. And I think right now we're in a vacuum. So as I alluded to during my talk, you know, we tried to systematically explore potential barriers or facilitators to adoption using a tool that had been developed by the US VA called an Organizational Readiness for Change Assessment. For those of you who may know, the US VA for over a decade now has had a concerted effort for quality improvement in clinical care. I can't remember what the exact abbreviation stands for, but it's their query program. So they developed the ORCA tool around an existing implementation science model for adoption. But looking at the questions that were asked, and it was a very, very lengthy survey, I think that one of the conclusions that was drawn was that maybe it wasn't the best tool to try to understand what we really wanted to understand, which is what are the barriers that are precluding people from utilizing this. And so I do think, and there are plans afoot, and I don't want to pressure anybody at this table to divulge things they're not ready for, but there are plans in process here to start to re-engage that exercise of exploring and understanding barriers, so that whatever we think might be an appropriate method to improve adoption is based on some evidence and not necessarily based on some guesses. That said, and I touched on it, but those who are involved in the CAF system know, we've certainly had institutional barriers that were imposed on us. So the fact that FAC was using the OQ Analyst cloud-based server, which would allow patients to complete an OQ45 in the comfort of their home the day before a clinical visit, was robbed of from CAF patients because of security constraints. And, you know, it took the crucible of the pandemic to shift the dial on that. And, you know, over the last, or about maybe 18 months ago, there was the introduction of a version which allows CAF personnel to complete Chromis at home. That said, you know, it seems that a large proportion of the clinical population are still unaware of that. So we can always do a better job of communication, and we do so through emails, but apparently not everybody reads emails. So we need to do a better job of getting the information out to people so they're aware that there are multiple options. So it sum up, I can't talk about what policy changes are coming down the pipes. What I can say is that if we want those policy changes to be effective, we need to go about selecting them in a more informed way. And so the plans are afoot to try to collect that. Do you have anything you want to add to that?
Denise, you want to, yeah, not to put you on the spot, but
So part of what we do in psychology, and I'm a psychologist, I can say this, and hopefully I can get away with it, is we rely a little bit too much on survey research at times. And there's definitely survey response burden in our population, in our patient population, and within our clinicians as well. And when we send out a survey, we are really making an educated guess at best as to what questions we should be asking. So what we would like to do with the plans that are underway is to take a different approach and sit together one-on-one with clinicians, conduct interviews with open-ended questions, guided by implementation research theories and frameworks, but open-ended so that if we don't include certain questions that we should have thought about, then we can make course corrections during those interviews. We are hoping to do the same thing with the patients as well, to get their perspective. So if we can do this well, if we can engage the clinicians and patients to give us that information as to what their perspective is, as to what the barriers are, but also what the facilitators are, what's making it easy for people to use measurement-based care when they can use it. Then we can think about policy solutions. But I think without clinician perspectives and without patient perspectives, it's difficult to come up with solutions that we can have confidence will work. So those are some of the plans underfoot, and we'll see how those unfold.
Venkat has something to add.
Yeah, I just wanted to add specifics from a non-military perspective, from a clinical perspective, and give examples as to how implementation is key. I mentioned about the Nielsen's framework and also Powell's summary of that with 73 recommendations of how to do implementation. It's often critical at the point of delivery where we've seen the same instrument delivered to that patient-clinician dyad is very different depending upon the patient and the clinician. So I'll give one specific example. When we started our work with app and wearable-based data capture, one feedback we got from the clinicians was, I only have 20 minutes time with the patient. They're coming in with all of this wearable-based data. I don't know what to do with it. So we had to come up with simplified ways of actually conveying what is important. That's one example. Another specific feedback we got was, I don't have time when patients say that they're not able to log into their portal or the data is not coming in properly. This was another specific example, and we came up with a new team member called Digital Navigator so that neither the patient nor the clinician actually has to spend time with, looking into technical aspects. So we took away the technical role from the clinician and the patient, and we came up with a new team member. So these are two examples where, the same platform, the same set of questions, you will need to adopt it based upon the specific setting.
So the take-home message is that one needs to be responsive and adaptive.
Thank you.
Like the CAF always has been, right? That's good. We'll just edit that out for the online version of the tape, right? So any questions within the group, or shall we keep? All right, Stephanie, take it away.
You make me laugh so badly. I have a question for Dr. Bath. How might your research in northern communities support policy recommendations that consider equity and access to timely quality of mental health care? Persons living in rural and remote areas do not always have access to specialist care.
Thank you for that excellent question. Part of the motivation for us to do that project was the precise question about how do we make access to care real time, and people in remote communities are able to get similar measurement-based care, or at least similar measurement-based care as people may be able to get in urban areas. So this is a 3-year project, which I mentioned, and we're just getting started. It's led by the Indigenous community. So we narrowed down to one community along the eastern seaboard so that we could show in a pilot manner that we're able to actually implement it in one community. When we started, we thought we could have more communities, and then we narrowed down to one community for this 3-year pilot project. So it is, an implementation, effectiveness implementation model. And the first year is all about in consultations with the community to see data sovereignty. How would we store this data and where? I think the privacy and security issues are really critical when we look at app-based or wearable-based or other modalities of data capture. So we're closely working with the community, and we will be storing all the data locally, and we had to come up with different workarounds to be able to store data locally. One other aspect, speaking of equity, is in the remote communities, access to Wi-Fi is actually limited. So we have to again find workarounds as to how do we make access to Wi-Fi available in these communities. The last thing I'll mention is how in all of the projects I've mentioned, we brought together virtual reality with app and wearables. So we've used 2D and 3D depictions of common mental health scenarios to train people on the front end. So most of the care in those communities is actually provided by nursing professionals, not physicians. And there are 7 physicians for Labrador, the 7 family physicians who actually visit these places once every 2 months. So we have trained people on the ground to recognize a common symptom, or we will train them, and they'll be giving input into what those modules will be. And also for them to interpret, going back to the previous point about all the data that's coming in, what do they need to know there? When you look at app and wearable-based data, what's the critical data that they need to know? So those are some of the ways we're actually working with the community. In 3 years, I'll probably have better results on the project.
Good answer. Yeah, go ahead, Steph.
Okay, now for it's a question on OSI clinics. Are there policies within the OSI clinics for the use of MBC for mental health care?
Gee, I don't know if I can speak to the policy level. I mean, I know it is absolutely encouraged. And of course, the Chromis system is essentially expected that we will use that. So at a minimum, we are supposed to be measuring, using the OQ45 on a regular basis with folks. But yeah, I mean, the clinic that I came from, measurement-based care was just a given, and we do it with all the different treatments and at a minimum sort of beginning and end of treatment. But one of the things that I learned today, because I'm always learning, is I should probably be doing it more often than that. I mean, the OQ45 is great all the time, but with my pain treatment, why am I just doing it at the beginning and the end? Why am I not doing it somewhere in the middle and making sure that we're on the right path? So that's my next thing that I'm going to be doing.
No, and that's a
I
great
veered
point. I
off,
mean,
but-
one of the things that we've talked about and with our friends at EHN is like, everybody keeps talking about outcomes, right? And outcomes is measurement, but it's not measurement-based care, right? Are you repeatedly doing the scales? Are you looking with your patient at it? And are you making decisions together about the next steps, right? So I think that's where, we don't want to burden them, but that's really useful data, right? And I think that's the point. And Brian, go ahead.
Yeah, so just one other point of clarity. So I know that there has been, since the CIMVHR forum in Gatineau, communication between the director of mental health for the CAF and the director for mental health in VAC. And I understand from the VAC director that they are trying to reinvigorate plans to promote better use of a measurement-based care system. I don't know the specifics of it, but I suspect in the coming months or so, people will learn more about that. I think one of the elements that they had talked about in my discussion with them, which I think emanates from some implementation models, was the idea of trying to have local champions at the clinic level, people who are trusted clinicians who believe in the use of some form of measurement-based system, who are there at a local level to promote it. I just don't know how far advanced that plan has gotten.
Yeah. We're just maybe one more. Should we stop there, Steph?
What are the key research recommendations that should be put forward to Canadian policymakers when it comes to MBC for military personnel and veterans? So it's a question for everyone.
Brian, you want to start? Mike's there in front of you.
So the question is, what is the key policy recommendation that should be coming forward from the CAF or other organizations with regards to MBC? I mean, if I'll throw in my 2 cents worth, it goes back to the question that Rakesh posed, which is, should it be standard of care? And when you have not regulatory bodies, but professional associations like the colleges of psychologists, of psychiatrists stating that it is standard of care, then I think institutions that are responsible for delivery of that care need to basically take a stand as to whether or not that is standard of care. And that's not my job to do it in my role, but I think that's something that the organizations, all the organizations involved in this, need to set their expectations accordingly.
I think that the questions around policy recommendations are very useful, but I think if we look at the history of professional organizations making recommendations, providing guidelines as to, let's say, for PTSD, these are the frontline treatments, these are the secondary treatments. There's always a gap between the policy recommendations or professional guidelines and recommendations and what's actually done. And we really need to think about solutions other than policy recommendations. So those would be my 2 cents. I think policy recommendations are important and helpful, but we really need to think about what are some other things we should be doing.
Just, I don't know if anybody else, but I was gonna you want to say something there?
Yeah, I would just add that if you look at other fields in medicine, non-mental health fields, whether it is HbA1c for diabetes, or you're looking at blood sugar for or blood pressure for hypertension, the gap between guidelines and what is actually practiced led to the whole QI, quality improvement domain. So looking at it in that lens may actually give us a few ways to actually implement it in the clinic. Although it's key to keep in mind that it's difficult to measure. It's not only doing the scales, but actually using it with the patient to improve care. It's not just counting the numbers, but actually using it in a meaningful way with the patient.
Not just measuring, it's using it. So Colette, did you?
Yeah, first of all, thank you for an incredibly stimulating discussion, the presentations and the panel. And I love what you were saying, Denise, about do we allow some room for innovation, adjunctive therapies, and what are those? And you know, with the CAF, it might be our somatic therapies. Like, we don't know that that's research based in terms of what it's being used for in treating PTSD. So yes, to your point as well, Rakesh, is we need to measure, you know, the research-based modalities and say this is standardized. That you should be using the kind of meat and potatoes. But when we then are working with clients, like what percentage is this kind of additional adjunctive innovative treatments on top of that? And then how are we measuring efficacy and plowing that back into discussion
Yeah.
with how we alter the treatments? Yeah.
No, you're right. I mean, I think in a nutshell, don't start anything without a plan to measure it. I've been saying that forever and it's never been done. But I think that's the key. I think don't have this great idea and kind of do this. So we're gonna, you know, just wrap up. I mean, you know, Dr. Serene's come back in the room and I just wanna, you know, we talked this morning about medical assistance and dying and coming for for mental health. And you know, the gang, the community did a good job of pushing it 3 years, but you can keep kicking the can down, but it's going to come. And it reminds me of where was that NATO suicide meeting? Was it Latvia? Riga, Latvia. And I was chairing this suicide thing, and I kind of made almost a facetious comment saying that we'll see in 20 years, we'll see suicide rates go down by 300,000 or 400,000 amongst veterans, but we'll see assisted death go up by about 400,000 or 500,000, right? So I think that's the key. But to me, how it ties this measurement-based care to some extent is we need to up our game, right? We need to up our game, and we're seeing people are going to start asking for, you know, dying because they've been depressed for 3 years. And then when we look at their files, they're going to be on 10 milligrams of citalopram with no CBT, right? I mean, so the idea of measurement-based care, being able to really say we've done everything we can for this person, and it really is hopeless, you know, fatal depression, treatment-resistant kind of idea. We have treatments for treatment-resistant depression, really exciting ones: RTMS, ECT, ketamine, psilocybin's coming soon to be regulated. And how are we calling it treatment-resistant depression, especially people that live in rural communities? We're talking about equity, people that are, you know, a few hours away from a university center. So I think to be able to solidly say this person has treatment-resistant depression, it can't be just my gut. This is as good as it gets, right? We're guilty of that. So let's do the measurements. Let's not have them replace common sense, but just say, look, 3 weeks in a row, it's been the same. We've increased the medication, we've switched, we've added CBT, we went from CBT to EMDR, we did this, and really document it. Because at the end of the day, if we're making these really serious decisions, literally life and death. So I do think that we need to up the game. And I think one of the things is the patients almost need to be coming and asking. Because if your father's a diabetic and the doctor doesn't check sugar level A1C for a couple of years, you'd kind of say, go into the doctor and ask for it, right? So I think that's kind of the way as well. So I do think that it does tie in, and it's not just an academic discussion that we're having, because I think the implications of not, especially now that we have treatments for treatment-resistant depression. Maybe they work 20, 30% of the time, but that's better than zero, right? So I think we need to do that. So on that note, I'll ask Dave and Stephanie to come up and sort of make some closing comments, but I want to thank everybody online and in person for their attention. And please, let's give a hand for my panelists for, you know, fantastic job as well. Thank you.
Yeah, so this is, this is Dave. So of course, I want to thank everyone online and here for the major contributions they made around this subject. So I guess we sort of started with this question: what can we do when treatments are not as effective in practice as efficacy results suggest in clinical trials? So it's clear today that the focus on measurement-based care implementation deserves a lot of attention to improve care outcomes. And I think when we started, Rakesh said, we're just getting started. This is the first step. So for me, it really begs the question of what do we do next? I think the case has been made that something must be done next. So I think that's the expectation that I would see coming out of this. So we look forward to learning more about that. And there were great ideas raised today. So CIMVHR's delighted that we were able to play a role in hosting this event. Thank you.
Okay, I would like to also thank Dr. Jetley for initiating this initiative. So we know it improves patient outcome, decreases treatment costs, improves health of treatment-resistant patients. I mean, why don't we do it, right? So this is exactly what Dave was saying. We are at that next step now. We really want to implement this. It will be a huge mobilization. How can I say that? Campaign that we'll be doing. Why wouldn't you apply, you people, my very dear colleagues and friends, to our upcoming forum, do a symposium on the topic? That would be great. We have until the 12th of April for this. The forum will be happening here in Winnipeg. So we're very excited about that. It will happen in October. And we hope also to do a special issue in our journal. It's, it's academic evidence-based and all of that. So more to follow for sure. You'll be hearing from us, about us, but for our people, for the serving members, for the veterans, for their better. So thank you.
Done. Yeah, that's it. Thanks, everyone.
All right.